Hello, friends of the Retina Channel podcast. Welcome to episode 76 of this series. Today, our topic is a bit different. It's not specifically about retina, although one of our guests is a retina specialist. We're going to talk about an important issue that I felt it needs some airtime, and that's equity, diversity, and inclusion in ophthalmology. We're going to talk about an article that's published recently in the Canadian Journal of Ophthalmology. And the title is Equity, Diversity and Inclusion Landscape in Canadian Postgraduate Medical Education for Ophthalmology Residency. And the authors of the study, and two of which are here today, will talk about the issue of EDI in medicine in ophthalmology. And I use this article to bring this EDI issue to forefront and educate everyone, myself included, about it and its importance. And I feel it made a difference in my understanding of EDI, and I hope you all benefit from it because it's something that more awareness is needed. And I'm thankful to these two authors who are willing to discuss about it and do a lot of work on it. Well, a bit of background about our guests today. One of them is my colleague at Mount Sinai Hospital, Dr. Nupura Bakshi. And Dr. Bakshi is a retina specialist, as I mentioned, and she also uveitis specialist. So she did her medical education degree and MD degree from University of Toronto. She also did her residency program at U of T, University of Toronto. She did fellowship in uveitis and medical retina at the National Eye Institute in Maryland. And currently, she's an assistant professor, Department of Ophthalmology and Vision Sciences at the University of Toronto. And she is also staff ophthalmologist, retina specialist at St. Michael's Hospital and Mount Sinai Hospital in Toronto. She has earned many honors and awards, including Kensington Eye Institute Award for Excellence in Surgery, and Dr. Michael Shea Award for Outstanding Contribution as a Senior Resident, also Department of Ophthalmology at St. Michael's Hospital, and Wilkinson Scholarship in Ophthalmology. She's quite achieved. She's a wonderful retina specialist, and it's my honor to call her my colleague at the university. Our second guest today is Dr. Nina Ahuja, and Dr. Ahuja also has a special place in my curriculum and in my heart, and she was the program director and during the second program director during my education in residency at McMaster University. Of course, Dr. John Harvey was the first program director, and then he gave the baton to Dr. Ahuja to do the leadership in that field. So, a bit of background about Dr. Ahuja. She did her medical school at McMaster University, and then she did her residency in ophthalmology at the University of Ottawa, and then she started practicing in Hamilton in 2003. She was one of the contributors for establishing and re-establishing the residency program at McMaster University in 2005, and she is currently the associate clinical professor and also the academic division head of ophthalmology at McMaster University. She's also the head she's also the president of ACUPO, or the Association of Canadian University Professors of Ophthalmology, and her important work she has been doing. She's been a medical educator, a health executive, and a certified emotional intelligence instructor, and also the author of a best-selling book, Stress in Medicine, for which she was here 2 years ago and talked about that work. She's also an author in Psychology Today, and also a founder of Docs in Leadership, which is an organization that she created to promote and deliver leadership in education in medicine. She has been a guest in podcasts in Canada, US, and Europe, and really discussed a lot of the issues of leadership in education, physician wellness, and equity, diversity, and inclusion. She has a wonderful Twitter or X handle, Nina Ahuja MD, and I encourage you to follow her on X. Without further ado, let's start the conversation with these two wonderful authors. Dr. Ahuja.
How are you?
I'm good. How are you?
Good. Nice to see you.
Nice to see you. It's been a while.
It has. How are things?
Things are great. Welcome back to Retina Channel podcast.
Thank you very much for the invitation. That's so nice.
I looked back, and it was just exactly 3 years ago that you were here. Uh,
Wow, is that right?
yeah, you were talking about your book, Stress in Medicine, and we talked about that. A great book. So welcome back.
Thank you very much. How are you?
I'm doing great. I'm doing great. Yeah, so busy as you know, and uh, you know, um, trying to looking forward to March break. We have the March break coming up, so I have a week off
Nice.
next week. Yeah, and Nupura, Dr. Bakshi, is gonna be a few minutes late, so if that's
Okay.
okay with you, we can start.
Yeah, for sure. Yeah.
And then when she joins, she'll chime in.
Yeah, for sure.
Um,
Sounds good.
so we're going to talk about your recent article on Canadian Ophthalmological Society Journal or Canadian Journal of Ophthalmology (CJO)
Hmm.
on the EDI equity, diversity, and inclusion landscape in Canadian ophthalmology residency programs.
Hmm.
And you were my residency program director when I graduated, so I'm always thankful to you for making me into an ophthalmologist. So this feels like full circle, coming back to you and learning more about this work you had done.
Hmm.
Um, you essentially did a cross-sectional study of programs and I guess program directors and also residents involved in the programs, and you had some questionnaire and try to identify where we are with the EDI. So I thought that would be a good opportunity to talk about EDI
Hmm.
and also specifically talk about this article, if that's okay with you.
For sure. Sounds good.
So Dr. Ahuja, as a leader of EDI and as one of the leaders in ophthalmology, I know you have done a lot of work in leadership. Just tell us about EDI, what it means, and because we hear about EDI a lot, especially the past few years or so. And so, what is the message? What does it convey?
That's a great question, Kayvan. And thanks for having me back on the podcast, by the way. It's
And
great to
my
see you.
pleasure. Of course.
So EDI, equity, diversity, inclusion is something that's really coming to the forefront in all sorts of sectors, actually. Medicine, of course, is one where it's so important because we deal with so many people as part of our profession when we're providing care. The concept is really about being able to provide individuals with equal opportunities for things that they're doing. In our case, as a profession, of course, but also when it comes to patient care, when we talk about access and um, opportunities for people to get care. Hello, Dr. Bakshi. Nice to see you.
Hello,
I
how
knew
are
proud.
you? Hello.
So that's really what it's about, is trying to draw attention to the fact that we do have diverse populations, we do have diverse healthcare providers, we do have diversity in our education systems as well. And so how do we provide opportunities for people so that everyone feels that they have a chance to pursue what they want? And then also, how do we ensure that the relationships that we're having are those that are really ultimately respectful of the differences that we have between us, whether that be related to gender, sex, how people identify themselves, religion, race, and all the other factors that we look at when we're looking at diversity. So ultimately, to me, equity, diversity, and inclusion is really about respecting people and making space for people to be who they are in the way that they want to be, so that they can really express who they are from their being, whether it be in a professional or personal setting. And in organizations, we're just trying to bring it to the forefront with formal policies to guide the awareness and to increase people's engagement in those types of thoughts and ideas.
That sounds so necessary, and it should be obvious, but it's not, you know. But I'm happy that this is being more recognized. Hello again, Dr. Bakshi. I just asked Dr. Ahuja about the concept of EDI and what it means, and what are you trying to identify and address when we talk about EDI. Anything you want to add to her definition of EDI and what's lacking, what we're trying to address? I know you're also a pioneer of EDI in Canada, along with Dr. Ahuja. So Welcome to the Retina Channel podcast.
Thank you. Thank you. I think Dr. Ahuja has had an amazing answer, and she is certainly an expert in this area. So just to add, I think, or to echo rather what she's saying, it is also about creating equity of opportunity. I know that sometimes EDI, and currently at the moment, I think there's a little bit of backfire against EDI, and it is not about providing advantages that aren't earned. It is about really creating equity of opportunity and leveling the playing field so that everybody has the opportunity to flourish and to succeed, because we don't all start from the same place. And I think that's really relevant for when we're talking about something like a residency program and a training program. And really, as Dr. Ahuja said as well, it is so people can bring their whole self to work and bring their whole self to their patient. And really, we know that EDI is so important in medicine, not only for the professional working environment of physicians, but also for patient care. Obviously, health equity, we know that there are so many disparities in medicine, and socio-demographic factors affect health outcomes, even in things like, even in ophthalmology, not just, in medicine, in general medicine, but, certainly diabetic retinopathy, glaucoma. These are all studied extensively in the literature to have impact from socioeconomic and demographic factors and racial factors. But we also know that when patients have better concordance with their doctor, so when the physician and the patient have better concordance, whether that's in terms of race or ethnicity or even gender, patient outcomes are better. So it isn't, of course, that we care, of course, about our professional working environment, but really ultimately it leads to better patient care. Diversity of people leads to diversity of ideas, and diversity of people also leads to better patient outcomes. And I think that's a really important part as well. So it's I think ultimately better for the healthcare system.
Okay, so it's really just to paraphrase you folks, it's about respecting, it's about recognizing that there are different people in the sphere of medicine or any industry, and that should be recognized and respected and treated equally, if I'm correct.
Not just treated equally, but treated equitably. So there's, I think, a critical difference between equality and equity. So equality means you treat everybody the same. Equity means that you are making sure that everybody has what they need to succeed. They have an equal level of opportunity for success. So I think that's often a common misconception. It's not about equality, it's really about equity. And equity is really the end goal of EDI efforts. So we talk about, we put E first, but really you're having the diversity of people, then you want to make sure that diversity of people feel included, that their voices are heard, that they feel safe, that they can express themselves authentically, and that in an environment where they're not penalized for being who they are. And then ultimately that leads to a society where their barriers are reduced. And that really, social justice and equity is the end game.
Okay, so it's not equality, it's equity. That means sort of having opportunities, having access to playing level field is or a level playing field. Is that what we're talking about? So you don't want to say they're all the same, but they have the opportunity to flourish.
Right. And we can look at that from the patient side. Maybe, for example, a diabetic patient, some patients need additional support in terms of, support for getting their medications, nutrition counseling, whatever. They need something additional because of the background that they come from. It doesn't mean that, you're just helping them to all achieve good levels of vision and good levels of diabetic control and reduce retinopathy, but they all need different things.
Okay. And Dr. Ahuja, you kind of alluded to this. It's not just in terms of your ethnicity, racial background, or gender. It's all sort of variety, everything that we're different from each other. It includes everything, correct? Like we have commonly talk about LGBTB differences and issues about that. So it also includes those, right? In terms of sexual orientation, it includes all that. Is that correct?
It does include that. And to add to what Nupura is talking about in terms of the equity idea, there are certain barriers that are in our society that don't necessarily let members of the LGBTQ2 plus community come out and really be themselves. And so in order to do that, they may need certain supports that other people don't. There's a really nice image and a nice graphic where you have three individuals who are trying to overlook a fence. one person's taller than the other person's shorter. So one person may not need a box to be able to look over the fence. Another person may need 2 boxes or crates to be able to stand on it and look over the fence. And then someone else may need 3. So in some of these marginalized group and minoritized groups, there are so many barriers there that they need more crates to be able to get them to be able to have those same opportunities. And so it's certainly in any realm of diversity, that's where that applies, whether it be a physical disability, whether it be how you identify, whether it be, what a racial identification or all the other factors, it really does encompass all of the differences that we have between us.
Mm-hmm. Mm-hmm.
And as ophthalmologists, we're dealing with a marginalized group every day. Our majority of our patients have visual impairment, and that's often an invisible disability. And yet I think many times our training programs don't really focus on that aspect. I mean, we care about treating the disease and preventing vision loss. What about the many patients we have who are living with vision loss? And those are all people who have a marginalized identity, who have a barrier against their participation in society. So I think as ophthalmologists, we should be exceptionally interested in this area.
Mm-hmm. So correct me, Dr. Bakshi, if I'm wrong. So EDI, the definition you're offering, doesn't just include the healthcare providers and the residents and the learners and the teachers. It also includes patients and the service recipients, correct?
100%.
Okay, so it's because I always think of EDI with organization and the workers and the employees, but you're talking about people who receive the services. How can we be more equitable towards them and respect them? Okay, very, very interesting and important. Thank you. So let's go back to the study you folks published about the Canadian ophthalmology residency program landscape. Could you tell us about the study in just the gist of it, so we know what you've done? If you don't mind, Dr. Bakshi.
Sure. Well, actually, maybe Dr. Ahuja may be the best person to address.
Yeah, so go ahead.
She helped to organize the study, but I'm happy to provide.
Tell us what you did, Dr. Ahuja.
She's the lead investigator, so I'll defer to her.
Yes.
No problem. Well, thank you. So the objective of the study was really to see where we're at when it comes to equity diversity initiatives across academic centers in Canada for ophthalmology. So we had run a 3-phase initiative through ACUPO, which is the Association of Canadian University Professors of Ophthalmology, which is comprised of the academic chairs from all the centers that have ophthalmology residency programs and academic departments. The 3 phases, the first one was really looking at CARMs. We wanted to see in the different phases of CARMs. So when you're looking at application reviews, interviews, any of the add-ons, the selection processes, what are different elements that we feel are important to look at from an EDI perspective? So, for example, access to electives in a certain center, opportunities to be able to travel to interviews. How are we judging merit when it comes to evaluating applications and applicants? So various factors like that, we are trying to identify what we can be improving upon to be able to level the playing field for applicants so that they have equal opportunity or more equity in their opportunity, as Dr. Bakshi is highlighting very nicely, so that we have residents or medical students rather who have enough exposure to the field in whatever ways they need to have that to be able to increase interest in ophthalmology and then to increase their likelihood of having enough exposure and opportunity to actually be admitted. That's one aspect. The second part of the second phase of the initiative was to do education, so that Dr. Bakshi was very instrumental in helping organize a session on allyship, so that we understand what are the concepts of EDI and what role does allyship play in actually living the concepts that EDI represents. And then the third phase was looking at what initiatives are we running currently at our various academic centers to really help drive EDI principles forward, both from a faculty development standpoint. That was the primary aspect we were looking at in terms of what initiatives are present, but also looking at it from the resident experience side to see what is the experience that they're going through in their day-to-day in terms of microaggressions, for example, whether it be from patients, whether it be from faculty, how do they feel about their opportunities for hands-on surgery as another example. So the study was really trying to get an overall view or concept of what's happening in our academic centers so that we can then collaboratively try to come up with initiatives that we can drive through all of our centers from this central body of ACUPO to make sure that we're all looking at this actively and to standardize things across the board as much as we can.
Of course, the first step in making any change is to know what the problem is or what the landscape is. So this is more gathering information to know what steps we should take. So wonderful. So let's go about those steps you just talked about, the CARBs, a medical student journey to get into ophthalmology. What did we learn about that?
Well, one of the things that was really important is we really need to be able to identify what merit is about. So what do we really consider to be an exceptional or a candidate who would really be compatible with ophthalmology as a profession? Right now, as we know, for myself, even would I get into ophthalmology today? Probably not. I did not have 30 research papers that a lot of our medical students have. But the question gets to be, does that really reflect true capability or compatibility and merit in the ways that we really should be evaluating to see if someone's going to be successful in the field? So that's one of the things that seems to be a little bit unclear and perhaps not standardized in the same ways across all academic centers, where some people are emphasizing research, others are emphasizing electives. We're all looking at all aspects, but the weighting can be different. And in some cases, there are no weightings. It's looked at as a holistic application. Those variances are something that are really important that we need to consider, because we don't want to have different measures across different programs that then impact our selection processes. And also, we want to make sure that residents or medical students, rather, who are applying to our programs, they've had an opportunity to really explore their opportunities and to have an equal opportunity or potential for admission to ophthalmology, even if they don't do 30 papers. So that if we can identify a baseline of what we think is reasonable in terms of demonstrating interest and capability and potential in the field of ophthalmology as a resident in the future, should they be accepted, those are things that become really helpful in leveling the playing field and making it a good experience for medical students to really authentically be able to explore what they're interested in, rather than having to be so strategic about it. So that's one of the big things. Another key learning was that EDI training is something that everyone felt was really important, that we need to incorporate into our selection committees, so that some programs have informal sessions, but not a lot of standardized, structured education. University of Toronto, though, and Dr. Bakshi will talk about this more, I'm sure she can comment on that for sure, is really leading in where we are in EDI. And so you can maybe speak to that, Nupura, in terms of what you have established. She's done a great job with their department over there. And it's actually model for many of us across the country to be able to bring those types of trainings into our system, so that we can make sure that our faculty evaluators and resident evaluators are really knowledgeable of the principles and are really addressing things and looking and considering things without biases that really seep into our consciousness without being conscious. So that's actually in our subconscious. So yes.
As a side note, if our programs don't get someone like you into the residency programs, there's something wrong with it. Things have to be changed.
Well, you're very kind of your bias with your program.
I remember the day you interviewed me at McMaster. So
I do remember.
I remember the day you interviewed me. So when you talked about the programs, did any signals come out? Are programs detecting that, or are implementing things to include these things? Or you said University of Toronto seems to be a leader in this regard. Any signals come out from the survey with that regard? Before I get to Nupura's sort of talk about U of T specifically.
Certainly. I think what was really nice to see is that all programs had an interest and they were motivated to bring these concepts forward for discussion and to increase awareness amongst faculty and residents. So that was really encouraging to see. What was also interesting is, of the 15 programs that we have, and we had responses from all 15 program leaders, leadership from all 15 programs, majority of them were actually in the early phases of development of EDI initiatives, so that we were looking at early, moderate, or advanced level of involvement, and majority of programs were in the early phases, except for Toronto, which is actually quite nicely developed. So it was an interesting revelation to know that okay, we're all interested, which is good, but B, we all have lots of work to do. And it's nice to know that we do have a center like Toronto where we can really turn to it and see what they've established and created and try to bring that across programs across the country.
Okay. Thank you. So Nupura, that I guess makes the second question obvious. So what is U of T doing? What are the initiatives that you're doing at the University of Toronto? You've been the EDI, one of the EDI leaders at the University of Toronto. So tell us what are the initiatives that they've been implementing?
I mean, certainly nothing is perfect. It's all a work in progress. And thank you, Nina, for the very kind words. But, we still have our blind spots and lots of room for improvement as well. But, we have a pretty broad EDI mandate that has the full support of the leadership of the department. And I think that is really critical that our leadership has been behind it from the beginning. And, we want to look at it in terms of different domains. Obviously, education is a huge domain. And we have a pretty fulsome EDI program that runs across residency as well as faculty development and grand rounds, as well as, specific education modules for any selection committee. So anybody who's on a selection committee, whether it's CARMS or faculty selection, has to go through unconscious bias training. And these are established modules that are available from the American Academy of Medical Colleges and other resources where they're specific around recruitment, whether it's postgraduate recruitment or whether it's faculty recruitment. So these resources do exist. It's a question of making sure that, that people are going through the process of listening and learning. And we also want to work on our departmental culture. I mean, I think that's a work in progress, certainly, and we're lucky to have many faculty who are in support of it, but we try and have events such as specifically we have a women residents in ophthalmology committee where we create a safe space and events for women residents to come and speak regarding their experiences. This is because of, previous disclosures of situations of microaggressions and other unpleasant experiences that made us realize that we needed to have an opportunity, a safe space. And many of the times we also invite the entire resident body, not just the women, because certainly change doesn't come just from the marginalized groups. It comes from everyone, including those in the positions of power or in the dominant identities to make the change. And we also look towards advocacy. We are trying to create a mentorship program. This is still early work in progress. But we really want to look at across all of the different domains and have a broad and inclusive program, partnerships, obviously, with the COS, with other departments. And to your question you were asking earlier, since I started this work, I've been approached by so many people in multiple other departments who have asked for ideas and inputs, and we've shared our plans from U of T, our strategic priorities for EDI, and I think almost every department now has an EDI lead of some kind across the country, and that's been a huge shift, I would say, within the last 2 to 3 years. So, while some of the programs are in earlier stages, I completely agree that there is an understanding that this is important, this is critical, this is a key part of, becoming, us training physicians or us training residents that are graduating, and also for our professional working environment, as well as for patient outcomes. And so we really have wanted to look at, policies and, administration, as well as education, as well as partnerships and advocacy, and also how do we create metrics around this? We don't have and this is, again, continuing to be a work in progress. We don't really have a key sense of organizational diversity at the national level, at the COS yet, or even at individual departments, because many times people who have an identity that is marginalized is protective of that identity because you can be easily identified. If you're in a small program and you are the racialized woman, you may be the only one. Or if you're from the LGBTQ2S plus community, you may be the only person in that program. And so it's often difficult to obtain metrics because you want to make sure that you're not, you're still keeping the survey or what have it is safe for the people that are answering it. And certainly we did encounter that as well within this study. So, those are the things we're doing at U of T. Specifically for CARMS, which was the original question, we have done a few things around this concept of what is merit. I think we kind of took that to heart because we previously had X factor, kind of, I don't know what we called it exactly, but suitability for ophthalmology, a kind of a fit. We know that concept of fit is so embedded in unconscious bias, and what does that mean even really? So we really used the AAMC has some wonderful resources, and they have a holistic candidate review process where as a selection committee, you literally go through all of the criteria and you define what they mean, you define what is important, and so as a committee you come up with a consensus. So for example, what is research about? Is that really about publications, or is it about intellectual curiosity? Is that the key value that you're trying to obtain for research? And how else can that be demonstrated? And so you want to come up with all of the different what are you really looking for? If people have done, electives in ophthalmology versus electives in something else, what are you really looking at there? Are you looking at dedication? Are you looking at compassion? What are the values that you're really trying to get at, that you need that you feel is important for a successful resident, a successful ophthalmologist? And really dig down to that and then define your metrics from there. And it's a pretty lengthy process, and we went through it about 2 or 3 years ago with our CARMS process. And it took a lot of work. Kudos to the CARMS selection committee that year. And really, that has to be refined. And then you have to say, how are you analyzing this? Is this, intellectual curiosity going to be defined by how many publications you have? Is it going to be defined by, I don't know, whether you have a patent? Is it going to be defined by something else altogether? Maybe, maybe there's some video game you developed. I have no idea. There's so many possibilities, a broad way of defining something like that. And so we have to really look at what that means and what are the aspects that define merit for success in medicine and success in ophthalmology. And so we went through that process. And then we also made sure the entire committee had extensive, unconscious bias and EDI training. And we also wanted to have a diverse committee. And I think having diversity of voices is really important. And we want to make sure that involves, across the spectrum from residents through to different levels of staff, that you have, gender diversity, you have diversity in ethnicity. So really trying to look at the different factors. And also in those meetings to make sure that the voices that are less powerful are also highlighted. So that's a simple strategy in a meeting to make sure that the person who may not speak as much because they're the resident and they're in a group of staff, that you make sure that the resident's voice is heard. So those kind of things were what we really tried to do, but by no means is the process perfect. And there's a lot of room still for improvement. But I think there's positive steps.
Those are important strategies, and kudos to you for being a leader in this area. And I think education seems to be really key here. I feel like we do all these educational modules, for example, about privacy. Whenever we do our hospital certification programs every year, there are these things we have to review every year, even though we have seen them multiple times. So EDI could be one of them. Why don't you review all those principles and all those things that maybe new, maybe not as new, but we have to review them because it's about human inclusion and diversity of us, So thank you very much. Just the last bit of the study that you published, you also asked about residents' perspective, how they felt and what they felt about their programs. Dr. Ahuja, could you talk about their responses? How did the residents feel about the EDI in their programs?
Oh, that's a great question. So overall, the residents felt that there were equal opportunities. However, there were many who had microaggressions that they were experiencing as well, and sometimes just overt instances where they felt that they were not being given opportunities for XYZ reason. With that, it highlights what Nupura is saying, where, we have these concepts in place, but it's certainly not perfect. The residents, it was an anonymous survey because we really did want to hear their perspectives. And some of the things that they were experiencing were quite surprising because they weren't just from patients, which was surprising in itself. But, I think I have certainly experienced that, but even from colleagues and faculty. And so seeing that and hearing that was very alarming, and it was disturbing, to be honest with you, because we're supposed to be educators, we're supposed to be role models in our systems. And if we ourselves are not aware, or we are aware, depending on, who you are, but I think most of us probably aren't aware of what we're doing, because I don't think we would do that intentionally to people, I would hope, in healthcare. But, seeing that these things happen, it's very, very concerning. we don't want to be making our learners feel this way. We know about the stresses and levels of burnout that they have already. Having this on top of that is difficult from that perspective, but also from a role modeling perspective. Residents and learners, whether medical trainees in medical school, nursing, whatever program they're in, they look to their supervisors and they look to their faculty members as, again, role models of how to be. And so if it's acceptable to say these comments, that's a problem. And when I say, is it acceptable? It's not, but when the accountability isn't there, that becomes the problem. And so that's where it's so important to have leaders who are aware of these concepts and who know how to manage these situations as well, because that's the only way that we're going to drive change. It's very easy to have policies. It's very easy to have modules, and all of those things are really important. But unless the accountability piece is there, nothing is going to change. And we see that time and time again, not just in EDI policies, but in other policies as well. So the residents, overall, they did feel that they had reasonable opportunities to do what they needed to do, to learn what they needed to learn. But there were certainly instances that should not be overlooked, and we really need to address in our academic centers to make sure that the residents do feel safe in their environment and do feel that they are having the opportunities that others are having as well, and getting the supports that they need to bring in that equity element that Dr. Bakshi is talking about. I don't know if you have any further comments on that.
I think the other thing that we weren't able to suss out exactly because of sample size was we saw a trend that those who were racialized or those who were women, so more marginalized identities, had lower rates of positive experience or greater rates of microaggressions. But it would be wonderful to be able to identify that a little bit or clarify that further. So, when we say overall, overall people felt safe, overall people felt, their programs allowed them to flourish, but within those groups, there were differences in answers. And so to really look at that in more detail, who are the people that are struggling more and how can we support those people more? There were some qualitative, the written answers that came in, which we didn't include, for confidentiality within the scope of the paper. I mean, some of those were heartbreaking, and really to that our learners are having those experiences within a program where they're supposed to be safe, where they're supposed to be learning, they're supposed to, saying have a role model that's so that they know how they're going to be as a physician when they treat patients. We never want to have anybody encountering those type of experiences. And I wonder whether some of these people that are encountering these experiences are those of groups that are underrepresented in medicine or those who have marginalized identities. And also, we didn't even look at what is the intersectionality of that. What is your experience if you have multiple marginalized identities? What if you are a racialized person from an LGBTQ group? What if you are a woman who wears a hijab? What if you are a disabled, man? What is the intersection of all the identities, and how does that affect your experience as a learner? And I think that would be hard to study, but I think that those are really important considerations as well.
And I think just to emphasize what Nupura said is it was a small sample size. So when I say overall that was within that sample size, but then again, with those subsets that Nupura's highlighted.
Yes. Well, this discussion really made me think about these issues. And just thank you both for really having this discussion and teaching me, and I'm sure everyone's going to benefit from this. Now, one thing that comes to my mind is that how do we make sure that this discussion and the EDI discussions we're having empowers each and every one of us and the marginalized people, especially, or people who are diverse and all of us included, empowers us while sort of increasing information. At the same time, it doesn't give people a reason to sit back and play the victim, So how do we make sure that the voice is empowering? How should we sort of take the message across so it's the information becomes powerful? Or is it just natural? It would do that anyway. I'm just thinking about it. Like I've certainly had to deal with all those things in my professional life. Sometimes you think I'm going through it, but you ignore it. But I feel if the issues are brought to the forefront, it's actually empowering. But You want to make sure it is doing that. Am I clear? I feel I'm formulating a question as I'm talking about it.
It's an excellent question, actually. Do you want to take it first, Nupura?
Yeah, I mean, I think one of the ways in which we can do this on a regular and ongoing basis is via allyship. And so I know Anina mentioned that earlier, but this is how we can all stand up for those who have marginalized identities or are experiencing harassment or discrimination. And so in any moment, most of us, as physicians, as we have identities of power, identities of privilege, and we have an opportunity, whether it's standing up for a colleague, let's say a patient makes a comment to our learner, addressing that in the moment with the patient or afterwards. Maybe it's you're sitting in a committee meeting and there's somebody who's quiet who may have good ideas, and you say, well, what do you think about what she, has to say, or what about her idea? And advocating for somebody else. Maybe it is, how you address your interaction of your staff with patients, like your ancillary staff. We have many opportunities on a daily basis to stand up for someone else and pay it forward. And I think that really is how we can all, in our daily interactions, really live EDI and not just think about it conceptually. And yes, it's important to learn about it. It's important to, make sure that we're aware of our bias, and on a daily basis, but really to live EDI and advocate for others. I think that's a simple.
I love that. I love that. So everyone is somehow a minority in some way.
Everybody we have multiple. Yeah. We all have multiple identities, and most of us are a mix of identities that have privilege and identities that lack privilege, and all have an opportunity to advocate for somebody else.
Yeah. So if you support each other, and then everyone will support each other, because no one. Even if you feel like, I guess we all say, if someone is a white male person has no disadvantage, but everyone has their own disadvantage. And everyone has, as you said, they may be visually impaired, and that's the disadvantage. So I think if you support each other, absolutely, we all benefit at the end of the day. Anything to add to that, Dr. Ahuja?
Yeah, I love what Nupura said, and I wholeheartedly agree with that. I think the other thing, part of your question also, is how do you make sure that people don't feel like the victim.
That's right.
I think outlook is a huge element of that. So that, when you have those experiences, rather than sort of feeling powerless, I think really looking at it and saying, why am I feeling this way? How is this impacting me? And how is it impacting how I relate to the world? So this is where I talk a lot about emotional intelligence and being aware of, how does that microaggression make me feel, and why am I feeling triggered? And then how can you turn that into a strength? By saying, I've just learned X, Y, Z about myself. Now, how can I use that information that someone else may not have yet, because they either haven't been in that exact situation or they haven't been able to work through that microaggression? And how can I actually help empower other people by taking what I'm learning as an experience that I can now bring to the world? So I think that's how you shift from a victim mentality to an empowered mentality, where you're actually taking all these experiences and you're able to look at the lesson behind it and then say, okay, how can I implement this now in my experience so that I can actually help advocate for other people and make myself feel empowered that I'm doing something about it, because I've gained this new insight that I can now help educate other people on to help address those sorts of issues. So I think that really does become a key element in terms of developing that self-awareness and understanding.
Makes sense. In a way, it's like psychotherapy. Yeah, you talk about the issue, bring to forefront, and you may cry about it, but eventually it empowers you because the issue is out there. So you find a strategy, as you said, to deal with it.
Yeah, and relying on mentors and colleagues and friends for support as well, and helping to navigate the system.
Wonderful. Well, this wasn't a retina topic. This is the retina channel, but Dr. Bakshi is my colleague in Mount Sinai, so she's a retina specialist. So it's retina enough, but it's very, very, very important. So
it's important for retina too.
It's important retina too. And I want to acknowledge both of you as leaders in our field for doing this great work in EDI and other areas, and educating us. Definitely, I learned a lot today. Dr. Ahuja has been my mentor and teacher for years now. So she has made me into an ophthalmologist, but they keep teaching me, and thank you for that. And Nupura, I learn every day from you and your great work. And your leadership. So thank you so much for coming to the Retina Channel podcast.
Well, thank you
very much.
Thank you for the opportunity and also the wisdom and insight to have an EDI topic on the Retina Channel podcast. And you've had some incredible powerhouse speakers in the past in Retina. And I think, I love that you thought that this was a great idea to put on your podcast. So thank you for that amazing work as well.
Of course, it's my pleasure. And I had two powerhouse speakers today as well.
Thank you, Kevin. And I have to say, it's been a privilege being part of your journey. I mean, I'm so proud of everything you were doing, and congratulations on everything you're accomplishing.
Yes.
It's a privilege being your student all these years. Thank you so much.
Thank you.
Good night, folks.
All right. Good night. Thank you.
Well, folks, that wraps up episode 76 of the Retina Channel podcast. Thank you for listening to this episode or watching this episode. If you haven't subscribed yet, please go ahead to YouTube and subscribe to the Retina Channel podcast. Now, all these episodes are also presented in video. So hopefully that will increase the effectiveness of education. I want to thank Dr. Ahuja and Dr. Bakshi for coming to the Retina Channel podcast. And even though this was not a retina topic, it was hugely important in our education, in ophthalmology, in healthcare in general. And until next time, I wish you all the best. Take care, and I'll see you next month.